Well, welcome to Crisis Jam, our episode 120. And in the pre-show, we were just giving a little bit of a video where Matthew Holtzclaw was talking about the deployment of Ukeru. Kim's going to give us a feature on the history behind this innovation and how they're working to support their own organization and now many others who are doing this really hard work. This crisis is the most rewarding, but it's also really challenging. It's 24/7. It's with individuals who are in a lot of pain or on maybe the worst day of their year or of their life. And in that agony, it's a ministry of presence. It takes the right kind of individual to bring that support and care and establish that good contact, but also be capable of helping de-escalate if someone is getting agitated. So we're going to talk a lot more about that during this episode. But before we get there, if you're a veteran of Crisis Jam, you know to go to talk.crisisnow.com. That's where you join the learning community. We've got nearly 3,400 right now of you who are on our newsletter, and you're going to get that weekly reminder. You can put it in your calendar. That's the direct connection to the community. Or you can just use this Zoom link, drop right in any week, and you'll see what's coming up, as well as at the bottom of that page, the highlights. Now, you can get to all the videos, the trivia questions, the PowerPoint presentations. They're all there under other materials, but you can also just catch up if you didn't see that. And that's all, again, at talk.crisisnow.com. And you'll see a t-shirt in the lower left of that website. You click on that link and it'll take you to this site where you can now get hats or long sleeve shirts. Amy Brinkley is going to show you the sweatshirt hoodie that you can get. And not only do you see the different versions of the 988 logo, but also the different quotes on the back. Amy, who's going to be speaking for NASBA today, is the author of one of those quotes. Secretary Becerra, author of another one. Pick the color, the size, the quote, English or Spanish, and you're off and running. But if you don't want to pay for something and you are looking to get magnets or posters or other promotional type materials, the SAMHSA website will allow you to receive up to 326 materials for free. So that's certainly the place to go. We've revised this slide with a little bit of a format change. Previously, we've been looking at these columns. But now we're also on YouTube, obviously, in addition to talk.crisisnow.com. This QR code will take you directly to the channel, but we want to highlight in a little greater fashion our most popular episodes. Robert Williamson back last year around crisis receiving in number 5. And new to the top 5 list is the special tech edition when we had Google and YouTube executives join us, which is now emerged at number 4. Dr. David Jobs and Derek Lee at number 3. And the top 2 episodes, these 2 special edition SAMHSA episodes, the Go Live event from last July with Dr. Miriam Delphin-Rittman and the spectacular special youth edition. Now, we've had over 1,000, almost 1,100 people who've seen the presentations through either they were there in the Zoom or they're watching it on YouTube. We are in the early stages of planning our next special edition event, which would be Miriam led us in the 20 speakers who launched 911 last July. We're now looking to this July 12th for 988 turns 1. And this is all draft at this point. John Palmieri, we're outreaching Dr. Delphin-Rittman and Monica Johnson about their involvement, but we'll be working on a lineup and welcome your ideas for that special edition that will be this July as we look back at what we've accomplished and look forward at what is yet to come. So some news items for this week. It's been somewhat of certainly a political issue at times, but we're now seeing both Republican and Democrat states really press forward with that traditional expansion of Medicaid. And North Carolina becomes the 40th state to do so. Tom Betlock will present later in this hour, former Arizona Medicaid director and our Republican governor and Jan Brewer many years ago led our, at that time, Republican-led legislature to bring Medicaid in because of the resources it brings in, not only to the broader healthcare system of behavioral health, but to crisis care in particular. And we'll drop the link into Richard. You had a comment about some of the states that haven't yet expanded and the impact on rural hospitals.
Yes, there was an article, and unfortunately, I don't have the link for it, but that was looking at the states that have not expanded Medicaid have had more difficult issues with rural hospital closures. I'm certainly not an expert on this, but obviously the needs of rural America are critical.
Great, Richard. And then we're just going to drop, for lack of, maybe I'll show it another time, but there's a great video from Oregon that is on their website around 988. And again, we'll hold this off, or if we have time later in the program, we'll come back to it. Great video from the Oregon team. I will show the quote of the week. This is from a hearing on the Health and Human Services budget this past Wednesday. Senator Catherine Cortez Masto with Secretary Becerra. So we'll play that quote of the week here.
In funding for 988, the new suicide and crisis lifeline has helped communities manage increased demand and call volume since the line went live last summer. I know I talk to my folks in Nevada all the time about this. On this committee, we're very focused on what comes next. What happens when someone in crisis dials the line and needs somebody to come help or somewhere to go for that treatment. I was proud with the chairman to pass increased funding for 988 and crisis care through mobile units in the December omnibus bill. But we have more work to do. So my question for you is, in your view, what is the biggest challenge to improving crisis care coordination when we're talking the mental health support that's needed across the country?
Senator, workforce. We need to hire up more folks, pay them decent wages so they'll stay in the field, because right now we know that healthcare has a shortage of workers, period, but mental health even worse. And so if we really want to say to somebody, call 988 and you're going to get real help, we have to make sure that there really will be real help at the end of that call.
Mention in funding.
So great quote from Secretary Becerra. And Dr. McKeon, this is the 7th time you've sat in the Crisis Trivia hot seat. Welcome.
Thank you, David. It's getting a little warm.
It's getting a little warm. Well, okay. So Richard, you and I were there, or at least I came and saw you. You were at the National Update on Behavioral Health Emergencies Conference that was in Scottsdale in December. And this month, they published abstracts, and I'm going to pick out abstract 12 by Kwong and some other authors that studied individuals with schizophrenia, bipolar, and related disorders that were presenting with agitation to hospital emergency departments. I was surprised in the article that actually over half of all psychiatric emergency department visits are associated with agitation. So in their study, in this abstract, how many individuals were physical restraints used on? It's slightly higher than 1 in. Is it 1 in 40, 1 in 25, 1 in 10, or 1 in 4? So Richard, we're going to get the audience's feedback on this. While we're doing that, you want to phone a friend. Richard, you've got a lot of friends at AAEP. Anybody you want to reach out to, or you want to talk this through?
Yeah, this is a great question. Unfortunately, I was not at that specific presentation. I was at the conference. So this would be a bit of a challenge. It's a really important question.
Richard, the audience says 1 in 10, but they're split. They're all over the place.
Okay, let me check. By any chance, is Michael Allen, who's the medical director at Rocky Mountain Crisis Partners and was our past president of AAEP, on the line?
Well, that'd be great. Michael, are you with us?
Are any other past AAEP members or presidents on the line?
Someone from AAEP, give Richard a lifeline. Richard, going once, Richard, you're on your own. What's your
Okay.
answer, Richard?
All right. So I am going to say that, and I think progress on reducing the use of physical restraints has been made, but I would say 1 in 4 there would be my guess.
Yeah, Richard, we've worked together a long time, so we know each other well. And there's a reason I did this question. I was stunned by this, Richard. It's a hospital emergency department, but this is challenging. When de-escalation techniques are unsuccessful, medication is typically used to acutely manage agitation. In this abstract, in their study, physical restraints were used for 55 individuals, or 27%. And security personnel were involved in nearly 40% of cases. So it's a reason we need to be chasing, how do we more successfully work with individuals in crisis? Kim, we're so glad to have you. Denny Morrison introduced us to Grafton and to your individual story, and how Ukeru came out as a company and a product and a service and support out of your own experience. So Kim, tell us all about it.
Thank you so much. And thank you for having me here. I'm super excited to talk a little bit about Ukeru. So first, let's just clear up this crazy name, right? So it's Ukeru, it's a Japanese word, and it means to receive. And so when we were first coming up with some of our techniques and strategy, the idea was that we don't want to fight against someone who may be physically aggressive or in a manner that's upset. We want to receive their emotion and their feelings. And honestly, we're going to show even how we can receive some of the physical actions that may come next. So Ukeru. So yes, we invented this right here. I'm sitting in Winchester, Virginia, at a place called Grafton Integrated Health Network. And I've been with this organization for 34 years. Started direct care myself, working with adolescent girls in our psychiatric residential treatment center. And I have to tell you, I started when I was 19 years old. And like many people maybe on the call that had their start working direct care, I got 3 solid days of training, a half a day with HR, a little bit of time talking about treating people with dignity and respect, and 2.5 days of restraint training. And back then we were using something that was called passive defense training. Got to tell you, nothing passive about it. And so basically at 19 years old with very little life experience, 0 work experience, put into a situation, people with big degrees, lots of experience, and telling me that this is the only way to do it, using restraint and seclusion. I think you could say that I was brought up in a manner that when people in authority positions tell you and teach you, you listen. So that was my start. I want to talk to you about where we are today at Grafton. As you can see on the slide, these are the various services that we're providing. Again, psychiatric residential treatment, therapeutic day schools, again, the gamut. So next slide, please. But if we're going to talk about where we are in a bit, it's only fair that I tell you where we were. And I hope that what you see is with great transparency. I think it's important for people to know sort of the good, the bad, and the ugly. So when I joined Grafton in the late 80s, basically what I saw through the 90s and into the 2000s was as children and adults were coming to us with more and more significant behavioral challenges and acting out in ways that were physically aggressive towards others, themselves, various levels of property destruction. As they were getting tougher, we got tougher. That's all, that's in a nutshell, we got tougher. We thought that meant we needed to restrain more, that we needed to use restrictive practices more. And so through that time, if you fast forward a little bit to around 2003, which was sort of like the height of some of our challenges, we were serving 220 individuals in that year, and we did over 6,600 restraints and over 1,500 seclusions. At that time, you could imagine we were being challenged with this understanding or myth that we were living by, that we thought we had to be more controlling in order to be safer. when in reality, as our numbers of restraints and seclusions rose, so did our staff injuries, our student injuries just kept going up. And I don't know how else to describe it, but we were stuck. And while we were stuck, the other things that were happening is our staff were injured so much that at one point we lost our private workers' comp insurance. So for a larger organization, that is not a good place to be. At one time, our insurance broker actually told us that our mod rating, so our risk of injury for our staff, was higher than the New York City Fire Department. And so you can imagine our staff were not very happy. We had a direct care staff turnover of about 54%. We had this silos growing and building across the organization between various departments. And if I look back, because as we all know, hindsight is so much clearer. If I look back, including myself, I feel like we were helpless, hopeless victims. It was sort of just the norm to feel like I'm going to come in here and sort of get my butt kicked again today, or I might be hurt today, or this is going to be a challenge, or we had sort of lost our creativity, and we sort of lost that unity as a team to provide like really super treatment. And so what happened, if you don't mind going to the next slide, what happened is around that same time, our CEO, who had been with us for 35 years, decided to leave. Now, I should tell you that our previous CEO, he was very formal, buttoned up, suit and tie kind of guy, spent a lot of time at the state capitol, at the legislature, wonderful man, grew Grafton. But I think what happened after 35 years, he was wore out. He was tired too. And so he retired. So we did a national search, sort of feeling pretty low. We did a national search and we found the gentleman that you see on the screen here. His name's Jim Gaynor. Now he has since retired, but he came to our organization when I have to say we were at our lowest. I always love to show this picture of Jim because that was actually his CEO picture on our website for some years, which again, you just look at that picture and you think super cool. Well, that was his whole demeanor and his whole style of leadership. So he came in and he was like no one we had ever experienced before. And he listened and he had this way about him of giving us hope back. And he really, what resonated is that he had this idea that together we can get through this and we can do whatever, it's going to get better. So he listened for a little bit. And then one day he came to one of our restraint and seclusion meetings, which we had for years and did nothing. And he really stopped the conversation and said, we have to do something. And he issued a mandate to the three of us who were executive directors, minimize restraint and seclusion without staff or client injuries. Next slide, please. And so we did that. So I went back to my team. We had a lot of talks. What it got down to is why in the world were we overusing restraint and seclusion? We got to these two reasons. Fear and frustration. Even if I think for myself, when I first started here at Grafton, there were days I was afraid, right? It's easy for me to admit that now. And there were days that I know I used restraint and seclusion way above and before any policy that Grafton said I should, right? Because if you pulled me by my hair to the ground yesterday, today when you are posturing and threatening, I'm scared and I jump out of safety and sort of protection for myself. The other thing is frustration, and people automatically think I mean frustration with students or clients, but honestly, that wasn't the frustration we were feeling. We were feeling frustration around bureaucracy and within our organization and policies and lack of support from managers. You know, we had this thing at Grafton, you get promoted to a manager, 9 to 5, Monday through Friday. But that's not good if the people that you're supervising work evenings and weekends. And so I was so fortunate to have a team of people. We all started direct care, and we really and literally flip chart started listing the things that made us bitter when we were direct care ourselves, and said, let's do something about it. Next slide, please. So one of the things that we started with was we want to do some basic things to keep ourselves safe. That's where the physical techniques and the blocking pads that were shown earlier of Ukeru came in. But then for the frustration piece, we really dove in with trauma-informed practices and what we call comfort versus control, and a lot of great de-escalation techniques. And so where we are today, as you can see on this slide, is we have 100% eliminated seclusion across our entire organization. That's been for about 10 years. The majority of our programs are restraint-free. The only place that we even teach a standing restraint is at our psychiatric residential treatment centers. So we hope that organically and naturally they are moving toward being restraint-free. Again, some of those places have gone from 200 a month to 1 or 2 a month. So we know they're on that path. The other thing is, of course, our staff injury has really dipped to the point that sometimes now we even do presentations for insurance companies, which is a great feeling. And with all of that, our goal mastery rose up. And again, finally, Jim Gaynor never asked us to find him like a great big bag of money. When he issued that mandate, there was not a peep mentioned about money. It was about doing the right thing. And he always said that if you do the right thing, all the other benefits will follow. Well, since we started this, we've been able to recapture, it's well over $21 million now for our organization, which as a nonprofit, that is amazing for what we're able to do with our facilities and for our employees, and then in general for our organization. Next slide, please. So in summary, this is one of my favorite quotes. Again, if you read this, I mean, I think 34 years ago, if you would have come to me in that girls unit and you would have said, one day Grafton's going to be seclusion free and almost 100% restraint free, I would have said, it won't happen. And like, we'll hair on fire, we're all going to die. But isn't that the way that most things happen, right? We evolve as humans, we learn better, we do better. And I can only hope that one day somebody will be doing a show like this and they'll say like, yeah, those silly blue pads and that crazy Ukeru, now we have even a better way. That's, for me, that's really what it's about. So thank you.
Kim, wow, thanks so much for sharing that history with us and the transparency of those frustrations and what was born out of desperation really led into this effective and really next generation approach to caring and engaging. So we're going to start our roundtable with Dr. Mike Riddle. Now, Mike, you've worked in this space of crisis receiving centers for many years now. You worked with Margie's team at Connections, worked with us here at RI. And in both cases, you got law enforcement cars coming up and dropping people off just throughout the day, every single day. They've not been cleared at a hospital. They're having a rough day. They're having big feelings. They can be agitated, frustrated. Tell us about your engagement post and pre and post Ukeru.
Well, I have to say, David, I truly love this program. It does exactly what Kim says. It helps staff tackle frustration and fear. And I think the frustration piece is tackled through this really extensive trauma-informed practice training. It helps people understand that someone's history determines the way they behave and the way they react to things, and it's so difficult to change. And so when you see someone and you get the same result over and over and over, when you've had this training, you understand that's okay. Today's a new day. This person wants to do well, and how can I help them? I absolutely love the story of the backwards bicycle because that says it all. When someone learns something and they've programmed their mind to ride a bicycle for years and years and years and years, and somebody does one little thing to change up the way it operates, you can't just say, oh, no big deal, let's do it differently because someone told me to, and just do it. You can't. You have to practice and practice and practice. And so I think when staff complete the Ukeru training, it helps them understand that. and they look at the individuals that they're serving differently. They look at them with more empathy, and they respond differently. And then it addresses the fear with the pads. And I absolutely love the pads. I've seen this looking in camera when I've watched the staff at RI use the pads. I've watched a guest who was extremely frustrated charge at a staff member who picked up a pad, and the guest did exactly what the Ukeru training said. They started punching, they started kicking. The staff backed up, but kept holding the pad. And the entire episode completely resolved itself. And without Ukeru, that would have ended up in a seclusion and restraint. Absolutely. And we have to, as mental health professionals, keep driving toward this idea, just like we do with suicide, that we can do this treatment without seclusion and restraint. We have to keep seeking less and less and less, and do everything that we can to bring that number as close to zero as we possibly can, if not at zero. And I think, we obviously are doing this at RI. We've brought our seclusion and restraint numbers down from, 7% down to 4% this most recent year. So only 4% of the individuals that came into us in crisis ever had a hands-on experience. And to me, it's still a loss for that 4%, but it's a win for 96% of the folks that come here. And you just can't say that in other settings. And you can't do it without these innovative tools. You can't just walk into a situation and expect to handle it, because it's a very difficult situation to manage. And you have to understand where the behavior comes from and really harness empathy and have the tools necessary to work through the challenge with the guests that you're serving. So I couldn't be more impressed. And every time that I have conversations with physicians in the community, I talk about Ukeru, I talk about how successful it is, how much it's helped us at RI. And I think it's going to just keep helping us more the better we get at it.
And Dr. Mike, you and Matthew created the video that we dropped in the link. Maybe in the chat, you can share just a little bit more. Obviously, Kim was in originally starting in more youth residential and in the large scale crisis receiving centers, where there is some use we use safe clinch at RI. Maybe you can talk just a little bit about that in the chat area. Let's go to Tanja Miles from more of a living experience sort of standpoint. Tanja, as you hear this discussion, and you've been received treatment, I don't know. I don't remember, Tanja, if we've discussed if you've ever had been physically restrained yourself. Tanja, talk to us a little bit about your reflections.
So yeah, unfortunately, I have been physically restrained, and that was back in the day. And to see how everything has kind of evolved into something different has really been amazing. Being a person who's been restrained, and seeing my mom restrained, seeing my uncle restrained, and also just working inside of different places, and particularly in prison. That's the kind of most one, and this is different. But, I guess I said that because you said something really cool. People are having strong emotions, big feelings. That's legit. You talked about a ministry of presence to understand that person that's in that state, our greatest harm is to ourselves, not to the person who we're encountering with. But of course, we want them to be safe as well. And I must tell you, when I first saw the training that was done by RI, it made me cry, because it was just so comforting to know that when someone is having a challenge and they need to be de-escalated, if you will, that there's something better. I'm also military police, so back in the day we were trained different on how to restrain folks. And at this stage in the game, I think that the training that is done, a lot of people can take that training on how to de-escalate, and then unfortunately, if they come into a situation like that, how to do it. I love the pads. I'm telling you, there's nothing like seeing a straight jacket or seeing a padded room and just, thinking, wow, how, inhumane that is. And so the fact that, like Kim said, when you learn better, we do better. And I never forget the first time when I went into a RI space, and I saw how safe it looked, and how that there were, no restraints for us. People are over here and the staff is there and stuff like that because of safety, you know, how soothing that was. And so, again, like Kim said, when we learn better, we do better. And this training is amazing. And, you know, for folks like me who have lived experience, it's so good to know that, you know, people are thinking ahead of the game, how to help keep me safe, how to help keep me safe. We want them to be safe as well, but how to keep me safe. And this training addresses that. And like you said earlier, a ministry of presence and a ministry of trauma informed. It's just a beautiful thing to see how this has morphed and, you know, changes to something better for those we serve.
Thanks, Tanja. Kim, there's a question in the chat text about emergency departments. How many organizations are utilizing Ukeru right now as part of their regimen? And are hospital emergency departments engaged at this point?
Yeah, absolutely. So right now we're over 450 places across North America and New Zealand are using Ukeru. And we are starting to see more and more interest from general medical emergency departments as well as urgent care centers. Yeah, so we probably have like less than 10 emergency departments and urgent cares right now, but that interest is definitely growing.
Thank you so much, Kim. So look, we're going to keep tackling this topic in Crisis Jam. And there's a host of ways, from the meaningful engagement of peer supports in this work, the use of collaborative engagement and respect and dignity and care. So there's a host of components that go into this. But I really appreciate Kim coming and telling the story of Ukeru today. So let's go to the SAMHSA update. Dr. Richard McKeon. Richard, we were going to get you a Crisis Jam t-shirt. You would have gotten one had you not mastered the trivia. But Richard, I think you could be 7 for 7 now that I think back on your sitting in the hot seat.
Well, this one was a challenging one, but such an important topic. Glad that it's really been given this degree of attention on the Crisis Jam. So I'll be quick with the update. I just want to make sure that people are aware that right now there are 3 notice of funding opportunities for suicide prevention grants that are on the street. You can access the notice of funding opportunities on the SAMHSA website. But let me just mention quickly what they are. One focusing on tribal suicide prevention and substance use issues. These are our Native Connections grants available to tribes, tribal organizations. Secondly, our zero suicide grants are also available. And of course, David, you're very familiar with that because the Zero Suicide Initiative really was originated at the Henry Ford Healthcare Center, but really got formalized in many ways by the Action Alliance's Crisis Clinical Care Task Force that you and Mike Hogan co-chaired. So the zero suicide grants focusing on strengthening suicide prevention within healthcare systems. And then finally, although the smallest of the 3 programs, it's one that I am particularly excited about. So our National Strategy for Suicide Prevention grants. And I'm excited about it, not only because we are on the cusp of revising the U.S. National Strategy for Suicide Prevention in 2024, but of all the suicide prevention grant opportunities that SAMHSA has released, this has the strongest language on reducing access to lethal means. So I really call people's attention to that. It covers areas regarding safe storage, storage maps, hotspots in the community, as well as some other critical issue. It also has probably our strongest language in a suicide prevention grant around suicide prevention among older Americans, an area where we as a nation have unfortunately not focused a great deal. So thank you for the opportunity, David.
Oh, terrific work, Richard. Thank you so much. Let's go to Amy Brinkley. Amy, the NASBIT update today.
Thank you, David. Hi, guys. So I want to point out that I got my sweatshirt from the hot seat from a few weeks ago. So thank you. I love my sweatshirt. It's so warm.
What's
So
up? What's the quote on the back, Amy?
it's my quote.
Of course, of course.
Thank you, David. So I did have some slides today, so we can go straight into the slides. I've done this a couple times now and I love the opportunity, but I wanted to give you guys some visuals this time. So a couple quick snapshots. I'm not going to talk about all of this, but I did want to point out that NASHBID is tracking and or working on a couple different crisis related things. So one of the first things I wanted to point out is that the NASHBID Research Institute added some peer specific data questions to our state profiles or to the state profiles last year. Some of those reports are now out. So one thing I wanted to note is that 33 states reported that they are working on recruiting peers. 45% of the states responded that peer wages are still too low, and 22 states are working on crisis peer trainings that are in various stages of planning and implementation. And an important side note is that all states responded except for 7. Another thing that Justin Volpe and myself are working on is best practices for hiring peer support workers with felony backgrounds. And then, as I mentioned on the last NASHBID update, we have a crisis peer paper that we're working on with Deb Heinels and Justin Volpe. So hopefully that will be out. Well, it will be out in July at the earliest. And we are finalizing our first rough draft. So quickly, the Office of Recovery Initiatives that we've been following closely are mostly the next generation ROSC. So the announcement was that will be focusing on mental health inclusion the next round. And then they're working on a peer respite cost benefit analysis, which is a number of states are very interested in. So next slide. We've also been working with Kelly Maston at NASHBID and the TA Coalition to incorporate a series of recovery specific webinars that I wanted to highlight here. So there's actually, they're not all on the screen, but there's actually 4 and not all of the dates have been determined. So if anybody is interested in them, it's the role of families in SAMHSA's Office of Recovery has already happened. There's one on how to build peer support ecosystems, one on peer voices and policy making in partnership with the Hogg Foundation from Texas, and then a recovery cafe network bringing recovery support to communities. Why I wanted to highlight these, even though they're not specifically targeting crisis, is because as I'm involved in all of these different spaces and peer specific spaces, the topic doesn't always come into the crisis space. Like I hear a lot of peer support expansion efforts happening, but crisis isn't always necessarily a topic of conversation. So when I'm there, I bring it up, right? So it kind of forces that conversation. So if we have any crisis peer advocates in this space, join the meeting. And if they're not talking about crisis, bring it up. Ask the question, where does crisis fit? So just wanted to highlight that. Next slide is our TTI applicant. So David Miller and Leah shared the slides, and I'm very thankful for that. So what I wanted to point out, though, is that 30 of the TTI grants focus on workforce development, and 3 target crisis and community trauma, and 11 target building crisis services that serve under-resourced and minority communities. So if you go to the next slide, you'll actually see, and this is the last slide, you'll actually see kind of where they land. And so what you can see is that North Carolina, for example, has 2 TTI grants focusing on building crisis services that serve under-resourced and minority communities. And then we have American Samoa and Hawaii that are focusing on crisis and community trauma. So there's a lot of stuff happening in the crisis space, even within our TTI. So that is all I had today for the NASHBID update. If anybody has any questions, I will put my email in the chat so we can keep the meeting going. So thanks for having me.
Hey, great stuff, Amy. We've got about a minute left with your section. I want to just, so Tony Sanchez did a presentation in Crisis Jam on busting barriers to hiring peers. Any other thoughts, Amy, on the work that you're doing to address past felony in the background of what could we see in Crisis Jam that would come out of that work you're doing?
That's a great question that I wasn't expecting, but it's a great question. So it gives me food for thought. So the SMI advisor toolkit is actually going to be targeting HR offices. And so we're
Right.
breaking it up into multiple sections on pre-hiring, as well as examples of applications. So there's ban the box, not all states incorporate that. And then each state has different ways of how they certify peers, right? So sometimes people get screened out before they're even trained. So there's going to be a lot of recommendations on incorporating people with lived experience, including criminal backgrounds. We can definitely share.
Yeah, terrific. Well, look, if for those of you tracking the chat, anyone who's been in a physical restraint or secluded while they were in pain, that's traumatic, and it lives on even when staff may have had the best of intentions. These are harmful, hurtful, and another huge element of changing dynamics is actually having individuals part of the staff who are peers themselves, who have a living experience, who maybe have had those prior experiences in place. So Amy, thanks so much for your leadership and ongoing work. And with that, let's go to Joanna Rosen with AFSP to start, and then we'll go to Sarah Corcoran with Guide Consulting for our federal updates.
All right, thank you, David. So Secretary Becerra of HHS has been going on his appropriations tour this past week and this week, testifying before several congressional committees. He had 2 appearances last week, the Senate Finance Committee and the Senate Appropriations Labor HHS Subcommittee. And he has appeared before several this week to discuss, the need for critical funding for FY24. He's been asked and he's highlighted the need for funding for 988 and crisis response services more broadly. We showed that clip earlier of Senator Cortez Masto discussing challenges to 988 and crisis care, and Secretary Becerra responding about the need for workforce expansion and retention, and the need for funding to bolster the workforce to sort of sustain the crisis services. We will have more clips for you next week for the hearings from the House Energy and Commerce, House Ways and Means, and House Appropriations Committees, so stay tuned for that next week. But that's what I have, and I'll turn it over to Sarah to take it away.
Great stuff, Joanna.
Thank you, Joanna. And in that same kind of FY24 vein, I wanted to flag an appropriations letter that was sent last week to the House Appropriations Labor HHS Subcommittee. That letter was led by a strong bipartisan group, Rep. Cardenas, Rep. Fitzpatrick, Blunt Rochester, Napolitano, Strickland, and Moulton. As a group led this letter about 988 funding, urging strong funding across the continuum for the appropriations items in the kind of 988 space. There were 33 sign-ons from different members of Congress on that letter. And in particular, it urged strong funding for the Lifeline itself, specialized services, the coordinating office, a workforce program, and one other item that I am blanking on now. Oh, I'm sorry, a public awareness campaign highlighting the advent of 988. So that letter was submitted last week and will be considered as part of the FY24 process on the House side. So it was great to see that leadership from so many members of Congress.
Great stuff. Thank you, Sarah. Thank you, Joanna. Let's go to Caitlin and Steph. Just last week, we were talking about the southern states and that from Arizona to North Carolina down to Florida was all gray. And suddenly, the very next week, we have Texas on the map in yellow. Let's hear about that, team.
Yeah, thanks, David. Some of our Lone Star State friends must have been listening in last week. Because yes, I have a new bill to tell you about in Texas, Senate Bill 2452. So this is a 988 implementation bill, really defines what 988, codifies what 988 looks like in Texas today, would set up that statewide trust fund that we've seen other states do, supported by a 988 fee, the exact amount not really defined in the legislation, and also sets up a 988 suicide and crisis line advisory committee, which must include an individual, a family member or caregiver with lived experience. And I will add, separate from this 988 legislation, of course, a lot of states are also working through their budget documents, and in Texas's budget, they have set aside, at least in the draft version, $37 million to support 988 and crisis response. And I think we also have Caitlin on the line who wants to tell us about a new piece of legislation in Pennsylvania as well.
Terrific.
Yes, thanks so much, Stephanie. So just want to go over House Bill 585 out of Pennsylvania, which was introduced last week. And it does not specifically call out 988. However, it does establish a behavioral health response unit and crisis call center program. This bill lays out duties for the Department of Human Services to work with counties and regions to establish local crisis call centers. It also establishes a fund specific to the centers, as well as a grant program that centers can apply for. Much like some of the other bills we're seeing, there also is an advisory group that's made up of consumers with lived experience, which is always good to see. So we'll be tracking this closely in Pennsylvania and seeing if there is any direct tie to 988 as the bill moves forward. So I will turn it back to David, and thank you so much.
Wow, Caitlin, thank you. And look, Richard was gracious with his comments earlier about some of our work historically. Let's give some credit here. SAMHSA's leadership, Richard, you and John and the whole team there, which, ultimately we had Congress pass legislation looking to states. And then Najbid, Brian, your team, the model legislation that was put forth with so many partners, and NAMI's amazing leadership with Reimagine Crisis, the map you've been doing, all of this work out of, again, AFSP, NAMI, Vibrant, and many others who've been involved. But gosh, Stephanie, this if Texas passes, will we look back at a tipping point here? It really, this map is starting to turn.
Yeah, I definitely think so. I would love to see one of our states that is, as you said, in the South, or just more conservative leaning, really pass comprehensive legislation. I think that would definitely be a turning point that we could point to.
Exactly. Great. All right. So let's get to, speaking of funding these resources, Tom Betlock is with us, former Medicaid director and also CFO and behavioral health commissioner in Arizona, and now with Spire Healthcare Strategies. Tom, we were going to do a trivia question, but all of these pieces, the 1115 waiver, the covered services guide, MCO network, crisis capitation rate, they're all the right answer. Tom, you're going to share with us some resources today.
Yeah, there are all a lot of details, David, in terms of how to make this happen. And so I'm always impressed with these discussions on the Crisis Jam because there's so much information that is shared. And I think an important part of this is sort of that financing piece. So yes, legislation is important, but even though you have a state like Arizona grayed out, Arizona has a $250 million plus crisis system, and Medicaid's financing over 3/4 of that. And so in a lot of the conversations that we've had, once we get to the details of financing, I think people are oftentimes looking for what is some of the specifics that we need. And the thing that I can tell you about Medicaid is it is a great financing program, but there's a lot of complexity to it, right? So we've got to get those details resolved. But the other thing about Medicaid is it's the ultimate copycat program. So if somebody figures it out, you just got to get a hold of that information and look to see where you can replicate it. So David, there's a couple of resources out there, but really this for me is a request to this amazing group that is brought together on a weekly basis to ask for your help in identifying additional resources that can be shared that states and others have put together around how do we finance these systems. So a couple of resources that we're going to put in the chat are Arizona has a crisis website. In there, they've got a couple of FAQs that target providers and broader stakeholders. And I think that when you look at some of the specifics of the FAQs, it gets down to the level of details that we really need in terms of how to pay for these services. So for example, on crisis phones, Arizona, the Medicaid system there identifies 80030 as a qualifying code with a modifier ET, right? That's way too much information, but the details exist. We know how to establish the infrastructure that's necessary to pay for these systems. Another great example of a resource that's out there is Virginia has put together through their work of their actuaries an 11-page document that details how they came up with the different rates that they're going to pay for different services. And it walks through all of the assumptions over the course of these 11 pages in terms of what their assumptions are around workforce and capacity and hourly rates and everything else like that. And they establish the different rates. So for example, for 23-hour observation, they come up with the rate that the state is going to pay. And so again, my request as part of highlighting Medicaid and the importance of Medicaid as a partner and collaborating with Medicaid in terms of being able to sustain and grow our crisis services in our states is being able to identify those details. We want to be able to share them. We want to be able to create resources that people can go to. There's been the calculator that's been done in others, but there's a lot of resources out there. We need to look to bring them to this forum and to be able to share them so we can continue to answer all of those specific questions that we need answers to so that we can engage our Medicaid partners and others in terms of ways to make these systems sustainable.
Great stuff, Tom. Lather, rinse, and repeat. Those three tools, the Virginia tool and the two FAQs from Arizona, we're dropping those links into the chat. And Karen, let's send out a special email to the learning community, again, just highlighting those three sets of details. And Tom, obviously, you all do work in this space to support those who are engaging this. So great stuff.
And there are others as well, David. So we want to see the details of what states are putting together. Let's share those. Let's make them available in this forum and let's push them out. So as people identify those resources, this is a great place to share them.
And I love that aspect of this learning community, Tom.
Yep, without a doubt, David. Thanks.
We haven't had a lived lens in a couple of weeks in this particular segment. Arrow Foster is with us. Arrow, give us a couple of minutes on as we start out in this journey of 988 and care that feels like care for those in crisis. How do we know when we've arrived from your unique individual lived lens, Arrow? Arrow, you're on mute.
As always, on mute. I'm so glad that you asked it that way because that's exactly what I've been taking notes during this. And I'm really inspired about all I'm hearing today about continual improvement. You know, as a person who was first restrained at the age of 6 in 1970 for psychiatric challenges, and I've had many experiences since then in many different venues with both physical and chemical restraints, the advances that I'm seeing right now, led by trauma-informed care, really show how far we've come in the past 53 years. And today, I've heard the theme of the importance of looking to the past to inform the now and the future. In 2017, I was introduced to a book called Living in the State of Stuck, and it was about modern technology and the advances that it gives people experiencing disability challenges. And one thing I always remembered from this book is how it warned of standing in a place of how great we're doing right now, and then the movement stops. And I think, you know, that is really something that we need to be cognizant of, and I'm hearing it here a lot, which truly inspires me. We need to acknowledge the progress and through continuous improvement, shape the future. I think Kim Sanders said it really well earlier when she stated that she anticipates looking back at Ukeru and saying, now we have an even better way. You know, when we feel we've got it now and that we're in such a great place, that phrase itself should really tell us, it should be the red flag that says there's still much more to do. And hearing the voices of lived experience and the voices of the allies and the people here and the people across the nation that are doing great work in legislation and moving things forward so these crisis programs can move forward, really, you know, it gives me heart that we are not living in this state of stuck. One thing I would like to see when I'm looking at the numbers is, you know, more dollars and assistance being focused on the peer runs, as they are often the first entry point for people immediately out of a crisis situation. There are also, as I see it, and I'm very involved in workforce development for peers, is there wellspring for people who are going to be on crisis team staff in the future, whether that is at a call center, on a mobile crisis team, or in a receiving center. This is a wellspring of people to tap into to help create that workforce. So I'm just happy that you invited me here. And David, I'm going to turn it back over to you unless you have some more questions for me.
Oh, thank you so much, Arrow. And I think that reminder, yes, we look back down the mountain and acknowledge the success and the progress, but we don't take comfort in the comparison to the past. We keep our eye on where we're headed, and there's a lot of work yet to do so that everyone's experience, gosh, you're hard pressed on if you have a medical emergency today, it's the worst day of your life. It starts getting better at every point, and there's compassion throughout, and we just have to keep chasing that. Thank you for that reminder, Arrow. Joining us from Sue Murray, what time is it in Australia?
Too early.
It's too early. It's the middle of the night. Thank you for joining us from Sydney. Sue, tell us about your interview with Dr. Michael Gardner. Sue's works with Stephanie and myself and others, our international correspondent for Crisis Talk.
Hey, great. Thanks, David, so much. Look, while suicide rates in Australia aren't among the highest in the world, we have had a really single-minded commitment from the Australian government to reduce the impact on our community. And they've established a national suicide prevention office, and it's one of the first in the world. And so I took the opportunity for this article of Crisis, this edition of Crisis Talk, to interview Dr. Michael Gardner, who's the CEO, and Susan Edgar, who is the chair of the Lived Experience Partnership Group, about their vision for the National Suicide Prevention Office. What's different about this office is that they intend to work across all of the portfolios of government, and so that we'll really see policy driven that focuses on reducing the origins of suicidal behaviour. So it's really looking to bring an emphasis on the social determinants of health. Now, interestingly, the broad approach isn't without critics, and I happen to put my hand up there and say, whoa, I'm worried about this. What about the health system? But Dr. Gardner says that that is not something we need to be concerned about. But I'm not going to tell you what he says. You have to go over to the article and read his response to that. But he does feel very strongly that generally the objective is to keep people from becoming suicidal in the first place, then providing effective care and practical social and circumstantial support. And doing any one of those things in isolation is not going to see the difference that they want to make with the upcoming national strategy. So Susan Edgar, she's the chair, as I said, of the Lived Experience Partnership Group, and their members actually bring together that unique and diverse insights and knowledge to the work of the National Suicide Prevention Office. And she believes that this is a really exciting move forward. Certainly for Australia, it really is bringing that whole lived and living experience to the forefront at a national level with strong Commonwealth government support. Of course, a consequence that I think all countries are facing at the moment is that of the workforce. And Michael says that this is definitely one of the serious issues that the NSPO is facing. They can create a new national strategy and put all the best intentions of the world forward, but without the workforce, we really are not going to be able to drive the change as much as we want to. And so they'll go on to look at developing a national strategy, the national workforce strategy after that. I think Australia has got a federated system, so it means that a really big job for the national office is to be able to persuade all of the state governments to take up the national strategy and support its implementation. Michael is very enthusiastic about that. He said all of the early contacts he's had has been very positive. So we're looking forward to our National Suicide Prevention Office really making a difference to the world of suicide prevention down under in Australia. Great.
Thank you
Thanks,
so
David.
much. Thanks for joining
Pleasure.
us, Sue. Our love to you
Pleasure.
and Colin. For those of you who've been tracking our Moving America's Soul and Suicide, we do have the final episode, which we're going to be putting out for final review, and we'll hope to publish in the next week or so. We'll look forward to joining you at NatCon. And next week, Cosette IL with Rahim, focused on community mobile response. Their motto, we must create real safety for our people with our people. They're going to talk about the power of this approach. So we hope you'll join us next week and track us at talk.crisisnow.com. Thanks so much.